Thank you very much. The fact that there are so many different parallel paths today tells you that cancer is a big topic and there are many different priorities. For most of you here, cervix cancer is not even within your radar. But what I want to share today is that there is something to take home for everyone, and I hope that you will take home some messages that's relevant to you, because this is the only cancer that we can eliminate. So globally, every 2 minutes, a woman dies from cervical cancer, and in Malaysia, every day, 2 women dies from cervical cancer. It is what we call an unnecessary tragedy. So I just want to start my talk with this little short video to give you the broad overview of what's happening globally and what are the interventions that we can take today.
Imagine the most important woman in your life dying from a cancer that is totally preventable.
Yeah, it's had an impact on a lot of my life.
My mother cried for me and she said, my daughter need to be saved. The worst day of my life.
It's the second most common cancer.
And we just keep on fighting, yeah. Lives are at stake. Question is, how's the world going to step up to meet that need?
And we have to do something.
We're going to travel the globe and discover how the world can rise up to the elimination of cervical cancer.
We know what causes it, we know how to screen for it, we know how to treat for it.
We have the weapon to prevent this from happening. We have a vaccine.
We've used self-sampling.
Cervical cancer is more prevalent in disadvantaged populations.
We have to think multi-generational.
Getting to the end game is a matter of political will.
We cannot waste a second longer.
Stand beside me.
Impact has the family that you leave behind.
Stand your
We have the tools. We call on governments to implement them with full commitment.
And really encourage every country to adopt elimination targets.
Nothing's gonna stop us believing.
It's so powerful. We are all moving toward this goal. Australia is on track to be the first country in the world to eliminate cervical cancer.
This is a story about rising up, about how human ambition can overcome the seemingly impossible.
We have the opportunity.
It can be done.
I'm there to protect you.
The fact that you see Malaysia being featured in this documentary is the fact that they believe Malaysia will be one of the first lower middle income countries to achieve cervical cancer elimination. This is where we stand on the global map. And I'll just show you where we are in terms of what we have achieved in our country so far and what you can do to contribute further. So when we talk about cervical cancer, it is a life course approach. There's no one point in time where you say, okay, we have to do this at age 30. We really need to look at the continuum of a female person going through life from the time they're born. They need to be educated, they need to be vaccinated, they need to be screened, and most importantly, they need to be treated if there are any abnormalities. Because in Malaysia, we are quite good, or generally in life, we're very good at screening, but very poor in follow-up. So while we look at the life course approach, WHO has given us this target of what we need to achieve. You know what I can do without this? Can you hear me?
Yes.
Okay. WHO has given us a target of what we need to do in the next 6 years. So by 2030, if as a country we can vaccinate 90% of our girls with 1 dose of vaccine, if we can screen 70% of our women with HPV testing at least twice in their lifetime and follow up those with abnormal screening, we will be one of the first countries to eliminate cervical cancer. We're not far, and that's why I'm always so excited when I talk about this subject. So just to give you a quick history of where we are today and how we've come this far. If you look at the association between cervical cancer and HPV, it only came about in 1982. That's within my lifetime, you know, because in 1982, Michael Jackson sang Thriller. And Dr. Faisal is smiling here because he remembers singing Thriller when we were in school. And Kate Middleton was just born in 19... So it's all within our life history. And now we hear that she's battling cancer. So all this is very close to heart. And in 1999, WHO then said that you need HPV to develop cervical cancer. 1999, all these things happen all within our lifetime, and so we're talking about achieving elimination within our lifetime as well. So this is a very unique cancer. From the discovery to the elimination, it will happen, or it can happen in our lifetime. So this is why we now know, because of what we've discovered, we now know that you need HPV to develop cervical cancer. There's no longer doubt that 99% of cervical cancer is caused by HPV. And therefore, we can have vaccines that have been invented in 2006, which are now widely available. And it's no longer a research vaccine. It is a vaccine that has been proven, and we're now talking about rolling it out. For all of you who are developing vaccines for cancer, think about this. Rolling out is a major issue because from the history of cervical cancer vaccine, we've had a vaccine that can prevent 90% of cancers, and yet today we're talking about equity, we're talking about implementation. So there's a story to learn even when you're developing a vaccine. Last time when I was doing HPV research, they always said your vaccines will only prevent pre-malignant changes. You can never lead to a reduction in cervical cancer. That's now no longer true. We now have good data to show that in countries such as Scotland, Australia, New Zealand, where they've had vaccination for a long time, they have now shown data that they can eliminate cervical cancer. Always important to bring it back. What happens here at home? We have had a vaccination program since 2010. Really a beautiful program that we can share with the world. We've had more than 80% coverage, but unfortunately our program stopped in 2021 for a while because of the COVID pandemic. After 10 years, what do we know? What has the vaccine done? Because we have had no sort of registry, right? So we have to think about ways. If you have invested, if the government has invested so much money in vaccination, what has it achieved for us in Malaysia? And this research was carried out in Selangor, but in rural and in main clinic kesihatan. What we have shown is that after 10 years, there was a reduction in HPV 16 and 18 infection by 91%. And that is consistent with global data. So when you show a reduction of these infections, you will see that later on in years to come, it will lead to a reduction of pre-cancer and cancer. So we've already demonstrated that if we vaccinate, you will see this impact, and we have proven this already. What is worth thinking about in terms of policy-wise is that the non-16 and 18, which are the ones that are covered by a higher valent vaccines, that has shown a mild increase in prevalence. And how that translates to a disease burden is yet to be seen for our setting. So in terms of talking about a cancer vaccine, which some of you are working on, you can see that HPV or cervical cancer vaccine is one of the first ones that can talk about elimination. But if we want to wait for just the vaccines, right, it'll take a really long time. And so So in terms of vaccination, we started off with 3 doses among the adolescents in the past. Then in 2016, we said, oh, 2 doses are enough. And now in recent times, the story doesn't get better. 1 dose is enough. And therefore, in Malaysia, we are now moving to a single dose vaccination for our adolescent girls. What do we need to fight for? Perhaps higher valent vaccines, and perhaps please to include the boys as well. So this is something we need to work on. 70% screening target, that's the tricky bit. Cervical screening, technically, if you walk into any of our 1,000 over clinic kesihatan, you can get a free pap smear. But I tell you, women don't have it done. I, as a gynecologist, rarely would keep to date of that every 3 years. So it is an issue in lower middle income countries where there's no call and recall system. And so fortunately now the world, the science is on our side, the technology is on our side in that we can transition from pap smear to HPV testing. We now know that primary HPV testing is the gold standard. Also no need to argue anymore, it's no longer the pap smear. It is HPV testing, and this is evidence-based grade 1. And so in Malaysia, we have a vision, we have a policy that we should transition along the lines of the WHO goal to elimination, which is vaccination, HPV testing, and ensuring that women are treated. So this one is an old one, but it's being updated so that the new target will be, we will be aiming for 100% HPV testing as we move to the near future. But a paradigm shift demands an understanding of the science. Now if I tell most of our clinics to shift from pap smear to HPV testing, the question, what do we say? Is it an STD? You know, how do we counsel our women? And so a pap smear is to identify abnormal cells, whereas an HPV test is to identify the cause of these abnormal cells. So this is why we now have a very sensitive test for pre-malignancy and for cancer. And it's not a local thing. Global adoption, once again, the rich countries are leading this. So why do we move to HPV testing? So this is the first bit of knowledge I want to impart to this group, so that even as women, when you go see your doctors, please ask to have a discussion about HPV testing. If I take 10 women now with a pre-cancer change and I do a pap smear for them, the pap smear is only effective in detecting 5 abnormal cases. So 5 women with an abnormal change in their cervix won't get picked up. Whereas for HPV testing, you pick up 9 out of 10. So if you have one screen in your life, which would you choose? You would choose HPV testing. So, but to scale screening, it's nice to have the science, but we need to address perception, and this is where if there are any educators among you, media people, please help us communicate these types of issues, because when we ask our own doctors, what do you think about HPV in general? Do you know, I'm very embarrassed by my own profession, because when we ask obstetricians and primary care doctors, what do you think? And 1 in 5 doctors think women deserve what they get. That's terrible. And then they already have an impression, oh, they've had sex early. So all these things need to be dealt with, and you already make an assumption that they have multiple sexual partners. All this will affect how we treat women if we have all this intention to discriminate. And if you are looking at behavioral science or you're looking at communication, please help us address this matter when it comes to communicating with the general public and with the doctors. So in fact, UICC and the Commonwealth Task Force even came up with a 13-page booklet that conquers the myths and misconception. The second misconception is that HPV screening is so expensive, let's keep to the pap smear. Remember, pap smear is every 3 years in your lifetime. HPV testing is as few as twice in a lifetime. So So the modeling has been done in 78 low and middle income countries in a lifetime. This is definitely a more cost-effective method, and this has also been done for Malaysia. So what HPV tests you order matters. I'm just going to summarize this. Basically, there are currently about 800 different types of tests in the market. Most of them, look at this, 90% of this do not have standards in line with HPV scientific community. Most of them, 80%, do not have published data. So when you're introducing HPV tests, please speak to a proper scientist to know what clinical tests you should be ordering for your lab, because there are 800 over in the market with only 13 that works. So all you need to screen is the high-risk HPV types, not the low-risk, because doctors don't know how to differentiate in terms of counseling. Low-risk, high-risk HPV, does low-risk become high-risk? All these conversations are happening in the community. And I can tell you, most of your laboratories in your hospitals have the machines that were purchased for COVID, and this can be used for HPV testing. You have the tests, you have the vaccines. How do you get women to screen? And this is where we know that self-sampling is a solution to scale, which means you don't need a healthcare professional. You don't need a man to examine you, which our women don't like. You don't need to lie down with your legs wide open. You just take a swab, and it's a low vaginal swab. And it's so accurate that even Australia, with its stringent rules, have said women can choose. You either have your doctors do it for you, or you do it yourself. So it is also supported by WHO, where healthcare professionals are now few and far between. They say, please, if you can screen, if you can allow women to screen themselves, let them do it themselves. So in Malaysia, we have done the studies. It is well accepted in all population. But please ensure you also choose the right test kit, because as many tests as there are in the market, there's also many test kits. So think about all this if you're thinking about a program in your country. So I just want to share this story with you because I find it very frightening, because not everyone understands what self-sampling is. We in Malaysia know self-sampling as a little swab, low vaginal swab. There was a study done in Philippines where they gave a woman a cyto brush and asked them to insert it and brush their cervix and take it out and put it into this. This is an actual thing, I kid you not. So if my understanding of self-sampling is that, thank you very much, I'm not going to do it. Now, the last thing which we do not pay enough attention to is follow-up. Please think about the women's journey in following up, because as Florence Nightingale says, the apprehension, the fear, the surprise, you know, when you do a test already, you're waiting for the results, you don't know where to go, and this you need to address a bit better. That's where navigation programs come in. And careful thought must be given to linkage of care. So I put this here because these are the practical tips when I teach my doctors in the colposcopy course about how to counsel. Don't use the word pre-cancer, because in the patient's head, when you hear pre-cancer, it equates to cancer. So you can use words like thickened skin. You want to reduce stress among the patients. It's not an STD. So communication is very important. And so let me tell you, if you communicate with phone, landlines and SMS, I can guarantee you 90% of your patients won't pick it up because they're afraid that it's scam calls. I don't pick up any numbers I don't know, but you can consider using WhatsApp. Because WhatsApp, they can choose whether they believe you or not. But if you call from a mobile phone to make appointments, unlikely they'll pick it up. Treatment, from very complicated treatment, we now have handheld treatment that can be done by GPs themselves, applying heat for 20 seconds. And this has been proven already to work. So my gynecologists don't quite like it because we learn this method of cutting, excising, using generators, but if you don't have cancer, that method is now as effective, and that tool is only $800 where you can treat and treat and treat. And many of the low-income countries are treating using this modality now. So I believe cervical cancer elimination can be achieved in Malaysia. I've shown you it is possible. We have hospitals that can treat, and therefore I think if we have an all-society approach to do this, we can do this well. So that concludes my talk, and I'll be happy to take questions later on.